my good rule of thumb is if you graduated pharmacy or medical school more than 5 years ago, take whatever you were taught for duration and cut it in half. So 7's the new 14 and 5's the new 10. We just historically have given too long of a duration.
The conversations around antimicrobial stewardship and actually making the intervention, easier said than done sometimes, and certainly more art than science. So I think when you're approaching clinicians, making sure to give them that benefit of the doubt by asking open-ended questions, let them know why you're asking, making sure that you're coming at it from a patient advocate perspective, because that's truly what you're doing at the end of the day, is advocating for patients.
Welcome to Medication Talk, an official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, and the most trusted clinical resources. On this episode, our expert panel reviews important concepts behind antimicrobial stewardship, along with tips to help limit unnecessary antimicrobial use. Our guests today are Dr. Madeline King, an infectious diseases clinical pharmacist and co-director of Outpatient Antimicrobial Stewardship at Cooper University Healthcare. She is also an assistant professor of medicine at Cooper Medical School at Rowan University. And Dr. Michael Deaney. He is an infectious diseases clinical pharmacist at Denver Health. He supports the hospital's inpatient antimicrobial stewardship program and infectious diseases consult service. You'll also hear practical advice from panelists on TRC's Editorial Advisory Board. Dr. Stephen Carek from the USC School of Medicine, Greenville, and Dr. Craig Williams from the Oregon Health and Science University. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. For the purposes of disclosure, Dr. King reports a relevant financial relationship with Shionogi by serving on the Speakers Bureau for Cefiderocol. The other speakers you'll hear have nothing to disclose. All relevant financial relationships have been mitigated. Now, let's join TRC editors, Dr. Stephen Small and Sarah Clockers, and start our discussion.
Now, we know that antimicrobial resistance is a significant issue in modern healthcare. In fact, resistant bacteria are responsible for almost 3 million infections each year in the United States, and they lead to over 35,000 deaths in that same time frame. Antimicrobial stewardship can help limit growing resistance, but some viewers may be asking, what is considered stewardship? There are many activities across healthcare that fall under the antimicrobial stewardship umbrella. They can include direct patient care, such as prescribing the right antibiotic and lab tests, but they also include indirect patient care, things like monitoring antimicrobial use overall and educating colleagues about best practices. All of these are interconnected to enhance antimicrobial stewardship. And stewardship doesn't fall on just one person. It takes a team. For example, while prescribers can ensure they order appropriate cultures and tests, pharmacists can help guide appropriate antibiotic choices, along with optimized dosing and duration. And the list goes on. And with that, why is antimicrobial stewardship important, Madeline? I can see some viewers asking, what are the risks from, for example, antibiotic overprescribing here? And why do we need to care about this?
There's a lot of things that go into antimicrobial stewardship. It's important to ensure that antibiotic use is appropriate. So one, not overprescribing, but also not underprescribing or inappropriately prescribing. We want to make sure that we're not losing antibiotics that we have in our arsenal due to development of resistance from overprescribing. We still want to avoid unwanted side effects in patients by giving them antibiotics that maybe they don't need, or inappropriate antibiotics. If they do need antibiotics, make sure we're giving the correct ones. So I think really focusing on an individual as well as a population level is really important, and that can be very hard to do. But I think it's crucial that we think about both of those components.
And that sets the stage to discuss how we can be effective antimicrobial stewards. First off, Michael, how often would you say antibiotic prescriptions are inappropriate? How common of a problem is this?
Sure. So antibiotic prescriptions are pretty frequently inappropriate, I would say. About 30% of antibiotics in the outpatient setting are considered unnecessary. And that is true to inpatient, where it's between 20 and 50% of antibiotics in hospitals that don't follow evidence-based recommendations. Some examples of inappropriate antibiotic prescriptions that I've seen in my practice, I think overly long durations are probably some of the most common. Bug drug mismatch can happen pretty commonly as well. And by that, we mean selecting an antibiotic that does not appropriately cover the pathogen associated with the infection. Drug disease mismatch can happen sometimes too, where people pick drugs that are not necessarily effective at penetrating into different spots where infections can exist. I think renal dose adjustments, lack of renal dose adjustments are an issue that can happen too. Lack of adjusting for things like weight, either overweight or underweight patients, and kind of like double coverage where you have multiple antibiotics that are achieving a very similar coverage in terms of pathogens, potentially just exposing patients to more toxicity. Doses that are either too high or too low. And then one of the most striking ones for antimicrobial stewardship, unnecessarily broad antibiotics that are wiping out a lot of a patient's normal microflora as opposed to targeting specific pathogens.
And maybe going to the outpatient arena, Madeline, what inappropriate antibiotic indications do you see the most in your practice?
Yeah, that's a great question, especially thinking about the outpatient setting, which can be really hard to monitor. I think one of the things that we think about, which is a mix between in and outpatient, is treating asymptomatic bacteriuria. So patients who have bacteria in their urine just due to like maybe pre-admission testing for a surgical procedure that has nothing to do with the urinary tract. And kind of educating people that, just because there's bacteria in the urine doesn't mean that the patient's at risk of developing an infection somewhere else in the body. So that's one that we think about and focus on a lot. And the other one, kind of strictly in the outpatient setting, is patients coming in to primary care, urgent care with respiratory symptoms and being given antibiotics when they likely have a viral respiratory tract infection, or being given antibiotics for too long of a period based on what their bacterial respiratory tract infection is. So I would say those are the ones that we see a lot in the outpatient setting.
Piggybacking a little bit off of what Madeline was saying, this is really common in pediatric patients with viral causes of things like acute otitis media, extremely common in kids. Oftentimes, group A strep too is carried asymptomatically, but still tested for in a lot of children. So when they have symptoms of sore throat, they can often receive antibiotics for that, when in fact that is a viral cause as well. So lots of opportunities in both adults and pediatrics for this.
And Michael, I know you've done some work on stewardship in the dental arena. Can you tell us more about that?
Yeah, there's definitely some opportunities. There actually are some guidelines published by the American Dental Association over the last couple years that have come out trying to guide this question, because historically it's been kind of vague when and how to use them, what agents, what duration, for what indications. I think what's really, really interesting when you dig into the guideline is that truly the indication for antibiotics in dentistry is extremely narrow. You need to be having specifically an apical abscess that is not able to be treated with direct conservative procedures by a dentist. And then there needs to be both pain and swelling on exam to really warrant antibiotics, as long as no systemic signs of infection are present. So truly, most patients don't warrant antibiotics. And if they do, it's very short courses of narrow agents like amoxicillin. The other indication for antibiotics in dentistry is for prophylaxis, either for patients at high risk of endocarditis or bone and joint infections with a prosthetic material involved. It's another thing that's worth familiarizing yourself a little bit with too, because the guidelines for endocarditis prophylaxis, both for patients undergoing high-risk dental procedures, it's really high-risk dental procedures, very invasive, not just your average cavity filling, A. And B, the high risk criteria are pretty specific and would not include a lot of patients. So it's usually worth a second look from a stewardship perspective.
Those are great tips, and it's a good chance to brush up on some dental aspects to stewardship. We know that antibiotic allergies and many ones that are dubious can have negative impacts on patients. Craig, how do you address questionable antibiotic allergies, and why is this important? Then maybe, Stephen, you can give us your provider perspective on that and how you address that.
Yeah, I'm gonna say the huge thing here, and again, I have the luxury of practicing on the inpatient side where we have patients with us for, a day or a couple days and folks that kind of help us in this area specifically. I think it's a more challenging on the outpatient side. And one of the things we can really do on the inpatient side is try to remove those unnecessary allergies so they're not recurring in the outpatient realm. The big thing here is penicillin allergy is by far the most common allergy listed. And we appreciate now many of those allergies, probably north of 80%, are not actually true allergies. So the very first thing to do is just explore with the patient, what is this allergy? And there's a couple nice algorithms out there to think about, is this really something I need to be worried about? So we classically worry about is the anaphylactic, IgE mediated, or something relatively immediate. So what we're looking for from the patient was there some severe reaction that occurred within several hours of you getting antibiotic? And that's going to be a huge red flag for us. And something like that, if the patient says, yeah, I had a severe reaction and I was hospitalized, or was in the hospital and I got worse, that's not something we would challenge in the outpatient side and only cautiously on the inpatient side. But very often that first discussion with a patient opens up a beautiful can of worms you can explore, where it's like, well, my mom told me I had this allergy when I was a kid and I've never actually had this antibiotic, or I think I had some nausea from this like 10 years ago. So just having that conversation is fantastic with patients. And the reason to do this is because beta-lactams are really very good for much of what we want to treat. So we're trying to kind of use beta-lactams and spare other drug classes where we can. And for us on the inpatient side, getting it off that list so it's not on the outpatient side is something we can do for our outpatient colleagues.
Yeah, piggyback off Craig, I 100% agree that this is a huge problem that we face, and a significant, overwhelming majority of these patients that say they have an allergy to penicillin antibiotics, and it tends to not be the case. And so, just in our practice, all we do is it's getting their history, it's gauging, is this a true allergy or is this a side effect or an intolerance you may have had from a certain antibiotic? It's exploring, the history of the story, and then learning more about what the patient's experience with this was. And there's a few options that we have in terms of, okay, when's the next step if we want to actually pursue either allergy testing, or which case we can refer them to allergists and they can do skin testing, or even if we feel like it's a pretty low risk environment, prescribe the medicine and just have them take the first dose of the medicine in the clinic, assuming that we have all the necessary supplies. And on the very off chance that there is an anaphylactic response, so we have epinephrine or the ability to triage and get the patient emergent care if they need it. But those are potential options that we may have. And sometimes it's just correcting and understanding their history. And they say, hey, I've had a history to penicillin in the past, but I did take Augmentin once and actually did fine with it. So I think I'd be fine with taking that antibiotic. A lot of this there's momentum from previous prescribers that I think carries forward with some of these. And sometimes we may not have the ability or the wherewithal to go on the EMR and change some of these and update some of these allergies.
Yeah, I'm glad you mentioned some of the challenges in the outpatient setting earlier and the skin testing. We were able to establish a skin testing clinic under our infectious disease division at my institution after working with our allergists, because like you're saying, it can be really uncomfortable for other providers to want to prescribe beta-lactams or penicillins when they see that allergy in the chart. And in our case, our allergists were overwhelmed with their patient population of other things to see. So they were grateful that we wanted to take on penicillin skin testing and take some of that away from them. And I know there's some literature about other clinics who have done similar things, but I think being able to actually delabel the patient, like you were saying, and take that out of their chart very confidently will help every other provider that accesses their chart, especially in these large health systems, feel confident in prescribing those antibiotics going forward.
Yeah, documentation is absolutely key, as comprehensive as you can. Something I've been seeing recently is a lot of patients reporting that their family has a history of drug allergies, so that's why they report it. And we know that drug allergies aren't really inherited that way. So that info is so helpful.
Yeah, put that in the MR too. Tell us that if that's what it is. Yeah, let us know.
And this is a great chance to spotlight our resource in investigating possible drug allergy or sensitivity. It lists helpful questions to ask patients when updating allergy histories to ensure they're complete. And this info can be vital for helping optimize decisions around antimicrobials. Stephen, what are best practices for using delayed prescribing strategies or watchful waiting approaches?
One practice I probably use the most is just dealing with upper respiratory type infections, sinus infections, patients coming in, experiencing a few days of congestion, rhinorrhea, sinus pressure, just feeling crummy. That there's typically the patients that come in are demanding some sort of antibiotic because they feel that it's helped in the past, but you know, based on our assessment, we believe it's more probably some sort of viral in etiology. So typically these patients, most common practice I have is we can kind of come to a shared agreement that, okay, let's try 2, 3, 4 days of aggressive symptom management, let their body be able to fight off whatever this viral illness may be, if that's the case, and then utilize either over the counter or even prescribed medicines to manage symptoms. And then part of that visit too is we send an additional prescription for a antibiotic to treat some sort of bacterial rhinosinusitis, whether it's amoxicillin or doxycycline, but really prescribe strict instructions for the pharmacy not to fill it until a certain day that we agree upon with the patient. So it does a few things. Hopefully it allows the patient to sort of clear whatever infection they may have. But if truly they're having persistent symptoms, that may be a sign that may have some more complicated infection. And now they have to sort of take the initiative to go to the pharmacy again to pick up that prescription if they're still having those prolonged symptoms. At least in my practice, that's probably the most common use of delayed antibiotic prescriptions.
Excellent. And then, Michael, could you give us some tips to help clarify if something is the right drug and or dose for the right infection? What can we do to help prescribers and pharmacists there?
Sure. It's a tough question because it really depends on what setting you're working in and how much information you have at your disposal, whether you can help clarify that information. Certainly on the inpatient side, there's lots of resources, usually institutional protocols, multiple team members to consult with about the patient, as well as chart information that gives you all that you need to know regarding patient's weight, their renal function, culture data. You can make very in-depth decisions that way. I think it's a little bit more difficult in the outpatient setting for sure. So one of the things that I think is good to highlight here, something that outpatient pharmacists and providers can do to kind of help clarify this information when they don't have a wealth of info at their disposal, is to really approach it from a patient counseling standpoint. Ask the patient, what did your provider say this was for? Clarify with them direct from the source, what kind of infection do they have? That can help you figure out if it is a drug disease mismatch or not, which is a potentially high yield intervention. Ask where the infection is, if they're able to answer that. Ask how severe are your symptoms now. I think trying to gauge the severity of symptoms is helpful, especially for some of the outpatient infections that patients are prescribed antibiotics for. So things like dental pain, acute otitis media, strep throat, things like that. Well, patients are sometimes symptomatic when they see their physicians. Oftentimes, if they're not having active symptoms at the time that they're presenting for their antimicrobial, they might not need that course anymore. So that's another way that you can tell if it's being done for the right infection or not. Otherwise, focusing your interventions really on clear mismatches. So infection drug, bug drug, if you have that information, any kind of safety issues where it's clear that something is being underdosed or overdosed. I think with duration, particularly in the outpatient, 5 days is common for most outpatient infections, 7 days for some more significant ones or inpatient infections. Antibiotic courses that go on for longer than that are certainly not out of the question. There's many cases where patients may need prolonged courses of antibiotics for various reasons, but they're usually special case scenarios. And they're at least valid to flag for further investigation on your part as a clinician or for further intervention. I think also something to just sort of flag when a prescription comes through is any kind of high risk agents. So seeing things like fluoroquinolones, clindamycin that are either just very broad antibiotics or associated with a lot of adverse drug events, seeing if there's a reason that a more narrow antibiotic couldn't be chosen.
Excellent. Those are great points to ask patients for sure. And with that, I'll turn over the mic to Sarah.
Thanks, Steve. I do want to jump back to Madeline quick and see if she has any additional thoughts on improving stewardship in community pharmacies.
I think stewardship practices in community pharmacy settings are probably the most challenging because community pharmacists, especially in a lot of the big retail chains, have essentially no information on the patient because they can't access, the hospital records, the clinic records. So I would love to say, empower community pharmacists and retail pharmacists to be more involved, to call physicians, to call providers and clarify things. But that would really require complete overhaul of the structure of community and retail pharmacies to allow the pharmacist dedicated time to do this. I think in their current structure, that's really just not feasible. But, going along those lines, I think point of care tests can be great. There are more and more companies coming out with rapid respiratory viral panels that can give results in 15 to 20 minutes, which we've talked about in some of our outpatient clinics in my health system. But those still require someone to be dedicated to taking a sample and monitoring the test for 20 minutes until the results come back. Depending on state laws, pharmacists may or may not be able to administer those, interpret the results. And then what if you have a respiratory viral panel that comes back negative, meaning the patient might have a potential bacterial infection? And so then you have to send them to a clinic if you don't have someone who can prescribe on staff. So I think there are definitely some key areas where community pharmacies and community pharmacy staff can play a role. But I think the biggest limitation is the structure of retail pharmacies and having the time and resources to do that.
Yes, thanks, Madeline. And this is a great chance to spotlight one of our updated continuing education courses, implementing rapid diagnostic testing, as more pharmacies are doing this. So search our available CEs by typing implementing or rapid in the search field of the CE portion of the website. And this CE is a thorough review of rapid diagnostic point of care tests, such as those that detect influenza, strep, COVID-19, hepatitis C, and test and treat models that can be used in conjunction with these tests. And Craig, I see, did you want to chime in here?
Yeah, it is an issue in the community setting not having the data on the patient. But like the huge thing you have is the patient. If you find out it's a urinary tract infection and you've got a prescription for 21 days, a Bactrim in your hand, at the very least, we shouldn't be part of the ongoing problem. So hopefully no one is saying, take all antibiotic until it's gone, because that is like 1990s advice that we're trying to get out of our curriculum. So we're treating patients and symptoms, and if it seems inappropriately long, at least don't say, take this until it's gone. So we're making sure our graduates know what's the appropriate duration for a urinary tract infection and community-acquired pneumonia. And they feel empowered to say, if you're beyond day 5 or day 10 and you feel great, hold on to this. Don't necessarily finish it, and let's follow up with your prescriber.
Excellent. We have an audience comment and question that fits well here. The viewer is saying, I struggle with antibiotic durations and asking, are there rules of thumb or resources I should use to help with this? So, Michael, do you have any go to resources that you can recommend for our listeners?
Sure. I can tell you that locally, what we did at Denver Health to address this issue, we had something called a Take 5 campaign that we publicized to our urgent cares, our ED, as well as our retail pharmacies in our integrated health system, kind of promoting the fact that 5-day durations are standard durations for many outpatient infections that are commonly treated. So, acute otitis media, community acquired pneumonia, at least for now. New guidelines are advocating for potentially even shorter durations in mild cases, skin and soft tissue infections, potentially sinusitis, urinary tract infections, etc. And kind of encourage providers and pharmacists to say, if not 5 days, ask yourself why, and is there a reason? So certainly anything that your own institution is doing. A lot of institutions are now publicizing their protocols on an app called First Line, which is publicly available, and different institutions from different states do that. So if you're curious what a certain institution might recommend for different common disease states, it might be worth a look. Other resources that you could consider, certainly the Sanford Guide, which is available both in print and on a mobile application that's really user-friendly and easy to search. If your institution has a local antibiogram that's published, that can be helpful. Sometimes that's available on First Line too, if you want to look at antibiogram data from nearby hospitals that serve different patient populations that might match the patient that you're interacting with. Some hospitals serve patients that are more immunocompromised, large academic medical centers. Some hospitals are more pediatric focused. Maybe those would be ones to look at for that. And then certainly there's tons of CE out there, as well as guidelines through the IDSA for most common infections that are worth brushing up on, especially as new ones come out. Community-acquired pneumonia recently had new guidelines published through the ATS this year that are worth looking at too, that address durations of therapy for community-acquired pneumonia.
Yeah, I'll said briefly, Sarah, that my good rule of thumb is if you graduated pharmacy or medical school more than 5 years ago, take whatever you were taught for duration and cut it in half. So 7's the new 14 and 5's the new 10. And if, to Michael's point, you want to call 5 the new 14, that's generally fine, especially in the outpatient setting as well. So we just historically have given too long of a duration. So that's a good operation framework.
I would also put a plug in for anybody who's not aware. So Dr. Brad Spellberg had an article out several years ago called, I think, Shorter is Better, where he did kind of like a literature review of antibiotic courses, durations. And he has a website that he updates, I think, pretty frequently. And what's nice about it is it lists the recommended durations for many different infectious diseases, strep throat, all kinds of things. And the nice thing is that he lists the literature that supports the shorter durations in those things. And I find it a really nice, concise resource. And I use it a lot when I do teaching to the medical students.
These are all great resources. Thanks for sharing. I do want to briefly talk about First Line that Michael mentioned. We've had a few audience questions about it. And if you aren't familiar with it, First Line is a customizable app or website that some organizations are using. And you can add institution-specific guidelines to help with the decision-making at the point of care. So really, helping that antimicrobial stewardship effort. So it does sound like more and more institutions are using First Line, so expect to hear more about this. And I also want to highlight this chart on our website titled Antibiotic Therapy: When Are Shorter Courses Better? This also reviews the appropriate duration of antibiotic therapy along with other considerations. So you can print this out for the latest recommendations. And Madeline, we always get the question, how can technicians help? So what can technicians do to help improve stewardship?
I think it really depends on, obviously, the in versus outpatient setting. Something that I've seen at our institution in the inpatient setting, at least, when we document how long an antibiotic is approved for by our stewardship team, it shows up on the medication label. And our technicians are the ones that are preparing the medications, putting the label on, and those things. So, they can really help the pharmacist out by noticing those dates. Like the antibiotic is approved through today. They're going to need approval tomorrow, or maybe they need approval today, and kind of pointing that out before the medication gets sent to the floor, reminding the pharmacist or checking with the pharmacist that they noticed that date. In the outpatient setting, like with many other things, it's a lot more challenging. But for those technicians who are really interested and dedicated, giving them a little bit more education about durations. Like, hey, if you see nitrofurantoin for 10 days or 20 days, just double check it with me because maybe that's not right, or point it out. Things like that, kind of small interventions that they can notice without necessarily having the knowledge of all the literature on treating different infections.
And then this next question is interesting. Michael, maybe to ask you first, how do you address questionable prescriptions when you get them? How do you address it with prescribers without damaging relationships? I'm sure those discussions can get quite spicy. So, how do you address that? And then also, on the flip side, how do you address it with patients? Love to get your thoughts.
Sure. So, as I'm sure all of my co-presenters can attest, the conversations around antimicrobial stewardship and actually making the intervention, easier said than done sometimes, and certainly more art than science. I think I would definitely encourage people that hope to make antimicrobial stewardship interventions that they really need to be sort of tailored by either the patient case or the person that you're speaking to. Some people prefer direct recommendations, very straightforward. Some people prefer to know the why behind what you're saying. And sometimes it's a little bit of art to try to figure out what each person appreciates and how to be most successful with them. I think the key thing in your approach is just when you're making the intervention, making sure you're just giving the other person the benefit of the doubt. I feel like that's the thing that's gotten me the farthest. Oftentimes pharmacists, whether they're inpatient or outpatient, they're not bedside typically and have a limited view of patients. We get to know them really well from the chart. We certainly have a lot of information about their condition that way and the different factors, but we're not spending a lot of one-on-one time with patients often and really seeing either the severity of their disease, particularly for high acuity patients in things like ICUs. So I think when you're approaching clinicians, making sure to give them that benefit of the doubt by asking open-ended questions, let them know why you're asking, making sure that you're coming at it from a patient advocate perspective, because that's truly what you're doing at the end of the day is advocating for patients. If things go south too, if there's no way to potentially escalate the situation to somebody else involved, like if you're speaking to a resident, if there's any way to talk to the fellow or anything like that, I'm a proponent of the idea that as long as there's not a major safety concern too, one stewardship intervention on one day isn't necessarily worth potentially ruining a relationship with a provider by pushing extra hard. Sometimes you may be the first person to deliver a new piece of evidence, for example, advocating for shorter durations. So while they may not alter their practice now, with repeated education and time, people often do come around, especially as you start to build rapport and trust with those people, because we all have the same goal at the end of the day, and that's to help patients. I think that's important when talking to patients too. A lot of these same principles apply, just kind of explaining why you're asking the questions you're asking and how you're doing it to advocate on their part, as opposed to interfere with any kind of care or act as any kind of antimicrobial police, particularly with antibiotic allergies. I feel like as an inpatient ID pharmacist, I've encountered patients that will occasionally, when you're interviewing them about their allergy, it can get sometimes defensive when you're either trying to challenge their allergy or try to relabel it as something like an intolerance, just due to potential distrust in the healthcare system. Letting them know, for example, in this situation, how you could mitigate that would be telling them why you're doing this. I want to make sure that if you have an allergy that precludes use of the antibiotic, that's something that we really need to take into consideration. The reason for that is that oftentimes these antimicrobials like beta-lactams that they commonly have an allergy to are first line for a reason, partially because of safety and partially because of side effects, partially because it's narrow spectrum, but oftentimes because they're the best choice. So, for example, it's Staph aureus infections, methicillin susceptible Staph aureus infections. There's data to suggest that there is better mortality with cefazolin rather than vancomycin. And that's outside of any kind of safety issues that go alongside with vancomycin too. And then usually when you come at it from that approach, people are able to at least, while your intervention may not be successful that time, are able to kind of get on the same level with you and you're able to have a peer-to-peer conversation.
I will say that I always greatly appreciate all the antibiotic recommendations that our pharmacists make, because these are hard choices to make at the bedside with patients. There's so many variables to consider. And I think just an overarching theme with this conversation is that the evolution of these recommendations has really sort of dramatically changed the paradigm that most clinicians were taught, right? Sort of like antibiotic decisions are not static, they're very dynamic. There's a lot of variables to consider. And oftentimes what happens in practice is it's just one of many, many decisions that you have to make in the care of a patient. And one that we can get wrong or maybe not think through as comprehensively as say of our pharmacy colleagues may have the knowledge and insight to. So again, with the core element, we want to take good care, high quality care of the patients. Pharmacists bringing these conversations with physicians, from my perspective, it does something but help strengthen the relationship because it allows us to make better, more informed decisions that can help take better care of our patients.
So I'll just piggyback on briefly. We like to teach it. If you really disagree with an antibiotic prescription for some reason, it's just a teaching, learning opportunity. And so often I learn things. So if I call up Stephen and say, this seems like the wrong antibiotic or different duration, he may know something about that patient or why he wrote that I don't know. So we've all got different pieces of information and just it's a teaching, learning opportunity to get on the same page together.
Yeah, I totally agree about making sure that the relationship between the pharmacist or whoever and the prescriber stays on a positive note. That's more important than in a single intervention in most cases. And I think reminding each other that we're on the same team and that team is to fight for the patient. I think it can be challenging in the outpatient setting. On the inpatient setting, a lot of times you can catch something in real time as it's happening. But in the outpatient setting, what I've noticed, and I think we probably all would recognize, is that there's no one that's really catching these prescriptions in real time to call and say, hey, I see that you ordered this. I would do this instead. Or did you mean to do this? Did you want to try something else instead, etc. So I think what I have found myself doing is I just have the opportunity to go out to our primary care, urgent care, and family medicine sites and meet with them to provide education. Sometimes it's updated literature, like, hey, did you know the UTI guidelines were updated? Is there anything that we can add? Because we also use First Line at my institution. Is there anything that we can add to First Line from an outpatient infectious disease standpoint that would really help you? Any guidance? And then I always take CDC resources, like the patient education resources on delayed prescribing or watchful waiting or symptom relief. I take those every time I go and meet with providers so they can give them out to their patients. So not only are we trying to help the providers, but we're trying to help the patients understand when they're not being offered an antibiotic prescription, why that is. So I think reminding everyone that we're on the same team, but also providing some education as we go along can be really helpful and go a long way.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or Prescriber Insights subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code MT1026 at checkout. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.